All right, team, we're going to try this one more time. I apologize for this super delay. Can you guys hear me at all?
Yeah, we can hear you.
Yes, I can.
All right, thank
Yes.
you. So sorry for the delay. And okay, good deal. All right, well, appreciate it. And you guys are able to see the screen that I'm sharing.
Yes.
Yep. All right. Awesome. All right, folks.
Yeah.
Apologize. Yeah, we had we just had new software uploaded in the system today, and obviously I tested it out. Yeah, crazy. Here we go. So we're gonna get started. So we're not holding you up and get you out of here on time, hopefully. We're going to talk about differential diagnosis, cervical and upper extremity neuromuscular conditions today. We'll get a chance to cover some different things, do some case studies, and do some specific questions as part of it today. I'll just be quick on myself. I teach at the University of Incarnate Word and serve as the Associate Dean of Academic Affairs. I did my training at Army Baylor University, and I was also on faculty for there for a number of years. And here in San Antonio, I live right north of San Antonio. I do clinical work in a very busy neurosurgery clinic, spine neurosurgery clinic, but I do the electrodiagnostic testing in that clinic. So I get a chance to every day when I see patients, it's literally like I was in clinic yesterday. I saw cervical myelopathy, saw cervical radiculopathy, carpal tunnel, and cubital tunnel, and then also saw a number of conditions in the lower extremities too. So I get a chance to really feel very, very fortunate because surrounded by brilliant students, get a chance to teach neuromuscular neuroscience and neuromuscular assessment. I get a chance to work with great colleagues and then also get clinic time. So these are real case studies that I'm going to share with you too. So the goal, kind of neuromuscular content, musculoskeletal content, we're going to hit a little bit of both of these today. And we're going to do it kind of in a case study and question-based format. Just big picture, again, on the content outline. This exam is unique in the sense that a lot of what you're going to be asked about is what you maybe wouldn't do in a clinical setting because it's really about safety. The goal of the federation who writes this exam is to make sure that you are a safe, competent professional provider. So that is the focus. That link that I give you up there, that's to the FSBPT. You can go right now and say content outline FSBPT and pull up what the objectives are of this exam, and it gives you some big picture. This is an example of that. So again, you can kind of see this is just musculoskeletal examination. What are the big things you need to focus on? So we'll hit some examination questions. We'll hit some evaluation differential diagnosis questions as part of today in the focus. But again, it's about outcome measures. What are some history and systems questions you would ask? One other thing we like to stress is across all the systems, health promotion questions, be prepared for wellness questions, healthy patients, how would you manage them? That's all part of it. So be prepared. That could be a piece of it. This is an example of a study schedule. And I just throw this out here to kind of say that you can see, like, as we break down your whole, if you're doing an 8-week study calendar, you can see that a big chunk of this is stuff that we're getting ready to talk about. We're going to get over and talk about some anatomy of the cervical spine, as well as into the upper extremities. We're going to talk about some conditions and differential diagnosis and examination of those. All right, so case studies. Let's do a case study, kind of talk through it. And I'm going to be quiet and let you guys read that for a little bit. So we'll do another 20, 30 seconds here. All right. So you kind of look at that body chart and again, this fits, kind of a radicular pattern. And then you got this numbness and tingling, but you also have numbness and tingling on one side, on both sides of the hand, both palmar and dorsal. And then on the other side, you have it palmar. So there's some differential diagnosis going on here, right? And also history wise, what's something that stands out in the history on this patient that makes you think about this kind of makes the complexity of not only the nerve diagnosis, but also the prognosis of this patient different? Chat in for me or come off the mic there. What do you think? Yeah, diabetes, right? Yeah. So this patient is definitely so diabetes. Number one cause of polyneuropathy or peripheral neuropathy is diabetes. So in this case, that's something in the back of your mind because we don't know about. I'm not showing you the lowers, right? But you've got numbness and tingling in both hands. Now it's not on the dorsal side here, but you definitely got a palmar. So things to think about, right, with this patient. The other thing about this is look at this pain referral pattern. So with radicular pain, patients who have radicular pain, and this patient is in the 50s. When you see this type of a presentation, you always have to think about, could this be cardiac? So be prepared for differential diagnosis questions, radiating pain down the arms. And in this case, especially if they're talking about radiating pain down the left arm, the side of the heart, that is also, especially this medial pattern. I mean, when somebody comes into me and they say, this is my pattern, I get concerned because if it's just this, if it's down here, well, that could be C8, that could be, this could be C8, T1, right? But if it's going through T2, T1, C8, all the way down the arm, I'm like, that's interesting from a neurological perspective, but also from a pain referral pattern. Guess what that could be? That could be the heart, especially if the patient starts saying, well, it kind of radiates up into my jaw, it kind of radiates into my face. Sometimes it's down both my arms. Again, when radiculopathy happens, it doesn't typically happen bilaterally. It can. I don't want to say it can't. But when so this would be a question. So a question that we'd want to ask, right? If they said, this is your pain referral pattern. They described this to you, this radiating pain down the medial arm that radiates up high into the side of the neck. Part of my differential I'd want to ask is, in your aggravating factors, is it worse when you're exercising, like when you're in aerobic exercise? If you're walking, if you're getting up and down, if you're moving a lot, do you feel like you have any chest pain? Do you ever get sweaty? All those things that you would do for heart kind of clearing, right? Because this is a classic. I just saw somebody literally 2 months ago who was referred to us to do an EMG for radiculopathy. They had some radicular pain, but it was a heart referral source also that they had. And so we obviously referred them right away, got them over to see a cardiologist first. So this is right out of JAMA. It's an old article, but very classic, and also not just classic, but it's been seen in a lot of different studies. But you can see, when you're starting to talk about radiating pain into the arms, especially if it's bilateral, that really speaks volumes about heart, right? Okay. So this patient did not have that. So when I asked her about, do you have any problems with chest pain, diaphoresis, shortness of breath, anything like that? Nope, don't have it with physical exertion, but did have, and denied radiating pain, numbness, tingling in the lower extremities of the face. So they said they don't have any problems in the face or lower extremities. They do have, though, balance problems, especially on unlevel surfaces. They said, if I get on an unlevel surface or I get on an unlevel surface at night, I don't do well at all. So it hadn't fallen, but it had some near falls. So again, another interesting history to consider. So let's talk about this. So in this patient right now, what you have, I'm curious, let's answer this question, and I'll give you, just like on the licensure exam, I'm gonna give you a minute and 19 seconds right now. All right. And I'll put up a poll so you can answer that. Ignore option number 5, just 4 options. Okay, good. Guys are knocking it out of the park right now, answering this one, right? Okay, we're going to go another 10 seconds. All right. So in this case, so the question is ruling out. So we want a really sensitive test, right? So this is not, again, we think about the levels of evidence. What you're seeing up here, all these are really good, right? They're good examination items and been used for cervical radiculopathy. The one you want to think about is on the exam, you're not trying to just memorize likelihood ratios. That's not the goal. The goal is thinking about mechanically which of these would be most stressful. Like which one of these could I do and go, absolutely. If that patient can do that, I can do that on the patient and they don't have symptoms. I can feel pretty confident that they don't have a problem. So out of these maneuvers, again, this is a pain relieving test, traction that makes them feel better. But and again, Valsalva, that's a decent test, but again, you're just increasing inner pressure. That this again does not have real strong psychometric properties. Both of these tests do. The upper limb neurodynamic or neural tension testing, right? So think about it. That maneuver, you're taking all of the slack out of the brachial plexus right up into the nerve root. That's a lot of stress on the nerve root. And then the Sperling's test, again, another test, very good, more so for ruling in than ruling out. So the correct answer here is actually neurodynamics or upper limb tension test, also called upper limb tension test. Okay. So again, this is not an easy question. And the reason that, again, we're not trying to frustrate you, we're putting questions up there that are like, oh, okay, yeah, I got to think through each one of these options. So again, all tests that can be used for cervical radiculopathy, but the one that is going to take up the most slack, put the most tension on that, and again, what is supported by likelihood ratios is upper limb tension testing. This is a really helpful chart. So as you're getting and preparing for orthopedics, you definitely, your musculoskeletal questions, your CPGs, you want to pull all your CPGs, your clinical practice guidelines across these areas, because this is a really nice way, because this exam is the differential diagnosis and examination questions are about compare and contrast. So across a number of different conditions, which test is going to be most helpful? And in this case, again, with radicular pain, we want to be looking at Sperling's, again, good test, cervical distraction, upper limb tension testing or nerve mobility testing, all as part of that. Where we get into this is when the specifics of it now. So kind of breaking each one of these down and going back and saying, okay, which would be most sensitive, which is most specific, is a place that you want to take a look. And again, I'm not asking you to memorize a bunch of likelihood ratios or sensitivity specificity, but clinically going back and looking through these at kind of where they're at. All right. So that would be for radicular pain. So again, just showing you here, helpful for ruling in. What's really helpful for all these. So Sperling's test, traction, distraction test, Valsalva, helpful for ruling in, helpful for ruling out. We really want to look more at down here at the neurodynamic testing, nerve mobility testing, also called upper limb tension testing, all helpful. And let me end that poll and I'll share the results. So this is not an easy question, folks. There's the results up there. Not an easy question. All right. And we don't do this to frustrate you, just to get back and kind of go, okay, I understand all these are on the prediction rule, right? But which of these are going to be helpful, most helpful for ruling in and ruling out? Okay, so this is the examination findings. So again, I'll be quiet. We give you the history on the patient. Now let's give you let's give a little background on this patient when we did some examination items. What did we find?
What is it? What is exactly is the question? I'm a little confused.
Well, it's not a question. This is just so what I'm doing is a little bit different than just questions. We're going to get to a question, but what we started with was the history. You're asking a good thing. We did the history. Now we're doing the physical exam findings. So these are all the physical exam findings that you have for this patient. And then I'll give you a question coming up here.
Okay, because a poll popped up, so I was a little confused.
No, sorry. I just put the poll up so I didn't forget to launch it once I got you to the question. Yeah. So we'll get to the question coming up. And so sometimes we just ask the question straight up with a little bit of history, but it's also good sometimes to do, especially now, and thanks for asking this question, is because now we have the scenario-based questions, right, on the exam. So you get you have about 45 out of your complete exam that are going to be scenario-based, where you get case information, and then you have to answer 3 to 4 questions off of that. So these are kind of case-based examples that we can build off of.
Are we still gonna have access to this like case study, like this information, we get the question? Because
Yeah.
I think
Well,
like
yeah, when
for
you
the
take the test, yeah, you will. When you take the test, you will have it. And you're bringing up a great point. Yeah, having the smaller, tighter section. What I'm really trying to do here is just walk through a case, right, and kind of use
yeah.
that as an example. Yep. But in the exam, the real exam, it will carry that information forward on each question. Yep. All right. So a couple things to look at here. So this? Do you think this is just straight up radiculopathy based on what you have?
No, it some of the things that stand out to me are like some of like the bilateral symptoms and then the Hoffman's reflex.
Yeah. What? And so again, we got a Hoffman's good, and we got bilateral lower extremity hyperreflexia, right? And we got Anna Hoffman's, right? We don't have a clonus or Babinski, but we have hyperreflexia in the legs, and we got this, which would be more consistent with what kind of a problem? Yeah, good, Ryan. Upper motor neuron problem, right? So this patient now, let's look at this. So their weakness is right triceps and flexor carpi radialis are in that side. And then as you look down into the examination findings, you've got bilateral hyperreflexia in the legs, and then you've got decreased pinprick across both the palmar and on the right side, dorsal and palmar, and on the left side, just the palmar side. So there's a lot going on in this patient. Now, and again, I'm challenging you with this question just because you guys are coming to the end of your clinical, you've been seeing a lot of real patients. In one question, kind of this scenario, you see how you could ask 3-4 questions off of this pretty easily. So in this case, this patient does have a Sperling's and they have neurodynamic testing. So, I mean, neural tension testing. So both of those are positive. So there's clearly a radicular component, but then you also have to look at this and go, oh, what's going on with this hyperreflexia? So in this patient, this is just an example of looking at a Hoffman's here. Let's see if I can run that for you. So this is a patient that I had, again, but just to kind of show that, you can see very clearly, that she's got just to a little bit of stimulus how much her fingers move on this, right? Not as much, not as pronounced on the right, definitely pronounced on the left. And you can see, and I hope that video is running well for you. Look at on this side. Look at how, I mean, I'm holding her index finger, which normally you don't, and all of her fingers are going down. That's somebody, definitely has some tone for sure. So, and she had, and we'll get to that. So in her case, so this patient, so gait deviation, yeah, the patient had ataxia. Patient has a positive Hoffman's. They're over 45. They've already got 3 of 5. And that 3 of 5 is really predictive of, yeah, myelopathy. So this patient has myelopathy as well as radiculopathy. So, so I'll ask you, and again, we're not just the open case study discussion here. What's the most appropriate management for this patient? Let's say this patient is come to see you, referred to PT. You don't have any imaging, anything else. It's a direct access patient that you're looking at. Yeah, we want to get imaging. What kind of imaging? Yeah, we'd want to get an MRI. Good. So those are all fair. What I just asked you was 3 potential questions. How would you manage this patient? Well, you could still treat this patient, right? But I would also like to get back to the primary care provider and say, well, yeah, this isn't just a radiculopathy. This patient's also showing signs of potentially cord compression. And you'd want to image them. And from a safety perspective question, what would be some treatments you may not want to do on this patient? Yeah, we would not. Yeah, there we go. We wouldn't manipulate this person, right? We wouldn't. This would. Yeah, we would need to be really careful with our approach with manual therapy, right? This would be even somebody that maybe if they get relief with traction, that I would put them in a collar periodically, not all day long, but a collar with maybe some just gentle range of motion, gentle traction, and I would and when I say traction, just that brace, kind of holding them up a little bit for gentle traction and get them imaged and then referred to see somebody. So again, just an approach of kind of thinking. And what's unique in this patient, look at this. So this patient had a large, big central disc at C6, C7, also had foraminal encroachment on right C7. So she had really, a narrow foramina, but also had up into the cord, compressing into the cord. So does it make sense? Look at this. If it's down here at 7, if that's where this compression is happening, would it make sense that the triceps wouldn't be hyperreflexic, right? I mean, because there's a lower motor neuron component here too. So where I'm going with this is you've got a lower motor component, which means you can't even get signal in, which means she's going to be low on reflexes or normal here, but she'll be hyperreflexic below this. Well, what's below your triceps reflex is your patellar reflex, right? Unless you're doing like pecs, which you can test the pec too. That's a unique one. But again, you want to go down to this is an example of, I wouldn't just do an upper quarter screen on this patient. If the minute I saw ataxia, I'm obligated to go down and do some sensory testing and some strength testing and some reflexive testing, and then kind of put the pieces together. Yeah. When it comes to spinal cord injuries, so cervical myelopathy is an example of a spinal cord involvement, right? So a couple things to think about as you study the anatomy. You want to think about and this also fits for all your central nervous system questions. So let's say the question was you have a demyelinating plaque in the posterior columns right here. Okay, that's where the patient. This is pretty common in patients with MS. They'll get demyelinating plaques up at C3, C4, real high in the cervical spine because guess what? That's all white matter. And what does MS like to do? It attacks white matter. So if this is where the cord compression is at, what are going to be the symptoms? They're all going to be lower extremity sensory loss because this is your sacral and lumbar segments. So where I'm going with this is on these cervical myelopathy cases or cervical spinal cord cases, you want to go back and study each one of these different kind of syndromes and correlate that to what the signs and symptoms are. This picture I'm showing you is right out of the review and study guide book. So it's a nice kind of consolidated place to go and go, here's all the cord syndromes, and in one place I can sit here and compare and contrast them. This same picture is in there too. This gives you an idea. The cool thing is, just like our cortex is somatotopically organized, our cord is too, right? So again, given a lesion somewhere in the cord, you want to be able to correlate that to what the signs and symptoms are. And that's part of what's going on here when we see this with the patient. Okay. Now I'm going to ask you, so we picked up two things in this patient. This patient has cervical radiculopathy. They have cervical myelopathy. But what about this left hand stuff? So remember there's that asymmetry in the hand where you had numbness and tingling on both sides of the hand on the one side, and then the other side you didn't. You only had it in the palm. So what are some other potential neurological conditions that you could think about with this patient that might cause that? Good, CTS, right? This could be carpal tunnel superimposed on this because the patient's got diabetes, right? So what's the likelihood of patients having neural entrapments with diabetes is exponentially higher than patients who don't have diabetes. So in this patient, when I did the nerve conduction EMG study, guess what? On top of everything else going on, they had carpal tunnel too as part of that. So where I'm going with this is being able to read a body chart, ask critical questions. And the thing about it is the part about us doing online office hours is we're preparing you for the exam, but most importantly, I want you to feel prepared for a clinic, right? And the reality is patients often don't just have one problem, right? They come in with multiple problems. This is a very complex patient, by the way. And just throwing that out there as you get ready to go to clinic, not to frustrate you, but just to say, you got this. You can walk through this and get to these kind of different areas and think about how this patient would present, right? So again, a lot going on with this patient. And as we kind of started off with that, back to kind of this history of where we're at. And so this patient, that's part of this whole differential with them. Okay, let's ask another question here. So with this carpal tunnel, I'll put a minute and a half on in that poll that I had up there that I've had up there for a long time now. You can use that poll. Let me end this poll because let me get in and restart it. There you go. So you got a new poll up. Okay, we're gonna go. We're gonna go another. We got another 30 seconds. All right, 10 seconds. Okay, I'm going to share the results. Here we go. So you can see the results up there. We got a little spread, right? Lot on Phelan's. We got some on monofilament 2-point, some on carpal compression, and some on Tinel's. All good tests, or all tests, I would say all tests that can be used for carpal tunnel. This is a purposeful question because of the fact that I think we spend a lot of time memorizing all these different provocative tests. The reality is the correct answer here is monofilament and 2-point static sensation. And so where does this come from? It comes from meta-analysis, systematic reviews. And then if you look at again, using the CPG, you can see that, again, this is an example of, like, in this patient, I could sit there and do light touch and sharp dull, right, as part of my testing. But if I really want to get that sensory loss in the hand, I need to pull a monofilament out. So be prepared, given somebody with a history of carpal tunnel, or you think it's carpal tunnel, you can see that some of the highest level of evidence that we have is either Sims-Weinstein monofilament testing or static 2-point discrimination on that middle finger. So these are really, again, from an examination perspective, we spend a lot of time, and I'm guilty of this too. I like doing all those special tests, but in addition to your neural screen, your upper quarter screen with light touch and pinprick, you also want to, in a patient, if you think it's carpal tunnel, you want to quantify it with some monofilament testing. All right. And what's nice is, based on what monofilament you use, it can be really helpful down at 2.83 for ruling out and at 3.22 for ruling in. So just by using two different monofilaments, you can get a really good assessment of that. All right. Yeah, good question. So if you guys look at the chat, great question. It's the other benefit of the monofilament isn't just diagnostically. It's in again, great question. It's also to categorize the severity of it. And so given this history, if you said the patient has a 3-point, is not able to detect a 3.22 monofilament on the right hand within the index finger, the thumb, index finger, and middle finger, then right then and there, this patient has moderate carpal tunnel. Great question, Ryan. Because, and this is where with staging, right? Not just diagnostically, but prognostically, then what's different about this patient? Now we're talking about, this is no longer mild carpal tunnel. This is moderate carpal tunnel. So this is a patient that I can treat, but if I'm not making a difference in their outcome within a short duration, this is somebody that that would benefit. The literature would tell you clearly that they would benefit from a release if you can't get them better with non-surgical intervention, right? So great question. And that's the benefit of that monofilament, is not only from the perspective of diagnosis, but also prognostically. Oh yeah, now we're not talking about mild carpal tunnel, we're talking about moderate. Do we need to know the CPG for all musculoskeletal conditions? So I think the most common conditions by region. And so again, we've laid it out in the review and study guide. I'm not saying you need to buy the review and study guide, but go back to your textbooks, right? Go back to, what were the top conditions that when we talk about hand, wrist, and elbow, right? So we want to talk about carpal tunnel, de Quervain syndrome, right? You want to just start listing those out. And the way you can list those out is use a review book, ours or another one. We list those out. We have them in tables. We compare and contrast all that stuff. Or in another, but if you don't want to get a review book, that's fine. Just go get the most cited textbook on the licensure exam when it comes to differential diagnosis is Dutton's textbook and McGee's textbook. And so if you already have those in your library, going back through those main textbooks is beneficial. Yeah. And kind of getting those big ones. But the reason, RJ, the reason I'm hedging here a little bit is I don't write questions. I mean, I don't write the questions, so I can't guarantee you one's on or not, but I can guarantee you this. the most common conditions that you went through in your program, those are all fair game, you know, and all things that I would put my time into, right? Okay, and then also last thing, outcome measures. So again, this coming in here, you want to go back and so Sims-Weinstein is helpful for staging the severity of it, but it may not be what you want to use. For an instance, what's the best outcome measure that we have right now when it comes to patient-reported outcomes? It's CTQ-SS or Boston Carpal Tunnel Questionnaire. What would be your outcome measure? So sometimes your outcome measure, like here, pinch, and lateral pinch is not a great measurement for diagnosis, but it's really good as an outcome measure. Really good as an outcome measure. So that's where a CPG, like, look at this one picture. You can walk through this and go, okay, I'm going to use these for diagnosis. I'm going to use this for staging for mild and moderate. And I know right away, if I see a patient with thenar atrophy, I know that patient's got severe carpal tunnel, right? I mean, when I see a patient that's got atrophy in there and weakness in their abductor pollicis brevis, opponent's pollicis brevis, I already know. And the other median innervation muscles above it are normal, and they've got a sensory pattern that fits, and they got a positive, Phelan's test and a positive carpal compression test. All the pieces are going to carpal tunnel. If there's atrophy and weakness, we got a problem. That's severe carpal tunnel, right? So that's a way to go at it. What's lateral pinch? That's just, if you can see me on the screen here, that's literally, it's a pinch gauge, and you're just that. That's what you're doing, squeezing that together. Yep. As an example of that. So you're at kind of like that. That's probably a better one. Is going here. All right. So let's do this. So again, this is just broken down. So this is in the review and study guide. And so what we do is we take that CPG and we just put it in a summarized table the same way, so that you kind of summarize that and you can kind of look, what are those examination items? And somebody asked a question like, what do I need to know? Right here is telling you what the high value items are and things that you want to be able to go back and look at. And also other piece, I didn't put this part of the slides up there, but intervention. What has evidence? What doesn't have evidence for intervention? So right here, that patient, I look at that picture, I go, if that's, again, it's limited to the median nerve, that's severe carpal tunnel. We call that, we refer to that as a simian hand, because that is when you lose your opponents, you lose your median nerve, your median nerve is not working. Guess what? You lose the ability to oppose your thumb. So your thumb is going to sit back almost in hyperextension because your radial nerve is still working. So your thumb extension still works. So guess what? Your thumb almost gets pulled back. Like, if you look at an ape or go look at a picture of a gorilla online right now, their thumb sits back like this. So we call it a simian or an ape hand. What's the diagnosis? What's the diagnosis for this patient right here, that patient? So what I'm asking them to do, I'm telling them, I want you to go tip to tip on both hands and as hard as you can, go tip to tip. Yeah, anterior osseous nerve. Awesome. Okay. So anterior osseous nerve. So, or what if it was the median nerve? What if your median nerve was lacerated at the elbow? You wouldn't be able to do that either, right? So anything above the anterior osseous nerve or the anterior interosseous nerve is going to make it hard to do this, right? So now, classically, what do we think of anterior interosseous nerve? If it's only motor and no sensory, and this is what they're having problems with, because if we remember, and back to the anatomy, your anterior osseous nerve branch off your medial nerve. It does what? It does your flexor pollicis longus, the tip of your thumb, flexor digitorum profundus of your index finger and your middle finger. So your ability to go tip to tip, that's all about your median anterior osseous nerve. Okay. So let me ask this, what nerve root, if it was damaged, would also make it hard to do this? Go tip to tip. Oh, just take a guess. Come on, man. You got a choice. C5 to T1. What do you think? What would control thumb flexion and index finger flexion? Yeah, it's more C8. Classically C8. C8's the nerve root. Okay. So again, but what else would you see with this? If it was C8, the other thing you'd see with this, right, is you'd start seeing other C8 muscles that are innervated, like your extensor indicis. That's a radial innervated muscle that has C8 in it. So, right, you'd be putting the pieces together. But I've seen this where somebody says, oh, this is an anterior osseous nerve problem, and then they didn't test the rest of the hand, and you're like, oh no, there's a little bit of ulnar weakness, there's a little median weakness, and it all is more likely C8, right? So all things to think about that could do that. All right, this can frustrate people. What's called Pope's hand, or the hand of benediction. And the good news is in the licensure, they're not trying to trick you. They just want to know that you understand the anatomy and have the knowledge and the differential diagnosis piece. The question really is about, is the hand resting or is it actively flexing? So I apologize. I've got all this sun behind me today. If the hand is actively flexing, right? If the question says the patient is flexing their hand, and when they flex their hand, this is what happens. They do this. They flex their last two fingers. They don't flex the other fingers. Is that a median problem or an ulnar problem? Yeah, that's median all the way. Nice. Now, if they're passively resting their hand on the table and it's curled up like this, passively resting, they're not moving. Yes, then it's ulnar. Perfect. See, that's the key is you want to make sure, is the hand moving or is it not moving? Because here's the cool thing. One of my favorite muscles in the body is your flexor flexor digitorum profundus. It flexes the tips of your fingers. And what's so cool is these two right there, index, middle, or median, last two are ulnar. So just by doing this simple little maneuver like that, you get a lot of median ulnar information and a lot of C8 muscle type information. Very, very helpful. Okay. The last one is radial nerve. So your radial nerve is what? That is wrist drop. And if it's wrist drop, though, where's it got to be? It's got to be right above the elbow or higher. Because remember, your extensor carpi radialis longus actually comes up and its origin is above the elbow. So, in order for you to have complete wrist drop, that problem is typically almost always at the spiral groove up here, right in the middle of posterior lateral portion of your arm. And that usually happens when there's compression up in here or a fracture. Yep, Saturday night palsy. Awesome. You guys are on it. All right, let's answer this question. I'm gonna straight up we got a normal straight up question now, and I'm gonna start a new poll too. Okay, poll is up. Just stop my video for just a little bit while I try to close that so it's not so bright. Okay, we're gonna go another 30 seconds. We got about, yeah, we got more time. You take your time. Okay, we're gonna go another 10 seconds. Got about 70% of folks who polled in. And this, again, lot going on with this patient, a lot of information. Give it a shot. All right, I'm going to share the poll. All right, poll is up. So again, in addition to the, again, you guys have been a lot of repetition on kind of mononeuropathy or like specific nerve, median, ulnar, radial versus a radiculopathy, right? So you kind of know which of those to look at, but be prepared given kind of a history or that plexopathies could be part of this too, right? So it could be a plexus problem. And we're going to talk through, kind of break the plexus down in a very practical way that you can kind of go, okay, in a minute, 19 seconds, I can break this down and figure this out. So this patient has a lot of pain in the right lateral shoulder, and they are having a hard time getting their arm over their head. They had a flu shot about 3 weeks ago. And now they are having, they don't have any neck pain, but they've got a lot of scapular winging. And they also have, they have no neck pain, scapular winging, or numbness or tingling or weakness in the hand. They have 4 out of 5 deltoid, supraspinatus, infraspinatus, biceps brachioradialis, wrist extension. So they've got a lot of weakness in a lot of different, what we would call C5, C6 muscles, right? So this is more of a C5 muscle, more C5 muscle. It does have a little bit of 6, more 6, more 6, more 6, right? So there's a combination of C5 and C6. And so, and they also have, this is key, this numbness and tingling radiates, right? It's on the outside of the shoulder that radiates to the lateral arm. So it's not just localized, like it's not just C5 or it's not just C6. It's kind of like the whole area down, kind of crosses 2 dermatomes. So when you start seeing things that are crossing multiple dermatomes, and when I say that it's, you have this, you always got to put in the back of your head, well, where do 2 dermatomes come together? They come together at the trunk, right? And then it travels down into a cord. So once you start seeing this diffuse pattern, you got to think in your head, well, gosh, could this be part of the plexus too? So in this case, what's most common here is patient has they have the key on this is that they don't have scapular winging, right? That's important. So what's important here is that they got this flu shot, right? And all of a sudden now they're having these signs and symptoms. And what's going on here? This is an upper trunk plexus problem. So where am I going with this is upper trunk plexus is going to be classic, and the weakness in the pattern of weakness is going to be similar to what you just see here. So what they have is they have deltoid weakness, supraspinatus. This is really a key muscle because guess what? Your first muscle innervated in your trunk is your supra and infraspinatus. So when we break down the plexus, right, this is the suprascapular nerve. That's supraspinatus. And then it's going to go down and it's going to go down into the cord and you're going to get innervation of your biceps. It also has this division that's going to go down and do what? It's going to also hit your axillary nerve. So the deltoid is going to be weak. So whenever I see somebody, the key is, do they have scapular winging or not? If they have scapular winging, I know it's a root problem, and scapular winging with everything below it. If they don't have scapular winging, but they have supraspinatus, infraspinatus, deltoid, right? They also have, we come down here, they also have biceps weakness. Then we come down here, they also have radial nerve because they get through the posterior cord. They also have radial weakness in the wrist extensors. That is more consistent with a upper trunk problem, which is what this patient has. If this patient just would have had numbness and tingling from on the outside of the arm, right, on the lateral portion of the forearm, I'll be specific, lateral portion of the forearm, and they had biceps weakness, this would be more of a musculocutaneous injury, right? So just kind of get your sensory pattern, get your motor pattern, and put those together and be prepared again, especially if they talk about traumatic type injuries, that the plexus could be part of it. This patient history wise, what's causing this? They didn't, where that history is telling you is that the patient, there was no trauma in this patient. This patient literally woke up and started having these really horrific pain, 10 out of 10 pain, developed weakness, and developed these sensory symptoms down the lateral side of their arm. This is classic of what's called brachial neuritis. So we see this a lot after COVID. We see it sometimes after, and then again, when patients get injections. So if you get, a lot of injections in your arm, you can actually get inflammatory process in the brachial plexus, which will cause the same exact symptoms that we just went over. So again, if you ever have a patient who comes in and they say, it's 10 out of 10. I can't move my arm. It's so painful. I don't want to move it. Did you have an accident? Did you fall? No, I didn't fall. The one thing you want to think about is, have you been exposed? Have you had the flu recently? Have you had any sickness recently? It's almost like Guillain-Barré, but it's specific to the brachial plexus. Have you had any injections lately? All those are things you want to ask with somebody who has atraumatic, not only pain, but numbness, tingling, and weakness. Yeah. And again, it has this classic kind of abrupt onset. Guess what? 1 to 2 to 3 weeks after they've been exposed. So what do we talk about Guillain-Barré? Guillain-Barré hits 1 to 2 weeks after somebody's had flu, immunization, sometimes, and other things. Yeah. Is it always specific to the upper trunk? Not always, but the majority of the time it's the upper trunk, but it can also hit the cord. Sometimes it's just limited to the cord, but most of the time, to answer your question, Amanda, it typically is the upper trunk. Yeah. That's the most common place where we see it.
Also, can you repeat what you just said before about like with the scapular winging, you said that scapular winging is a more common presentation if it's a root problem versus like if
Yeah.
no without scapular winging,
Yeah.
you're more susceptible. You'd be more think you'd want to just I guess it's just look at the other symptoms as well, but why exactly would scapular winging indicate a root problem? Because
No, great question. So think about it. So if what nerves come off of the root level? So again, if I divide this up, right? These, this is trunk, that's trunk, that's trunk. Everything here, right there, that line is trunks. Everything proximal to that is your what we would term as in the root area. So think about it. What muscles control your scapula? Well, your serratus anterior, right? That's innervated by your long thoracic nerve, which where does it get it? It comes right off the root, right? It's innervated by 5, 6, 7, right off, and it's at the root level. Your
gotcha, okay.
dorsal scapular nerves, your rhomboids, right? Guess where that comes off? At the C5 root level. So that's where, and thank you for asking that question because it's super helpful when you're reading one of these questions. If there's scapular winging, as well as everything below that C5 and C6 is involved, I know what the roots have been damaged. And often what'll happen is it's more likely to be trauma. Like they've been in a motor vehicle accident or a motorcycle accident, their head got pulled away from their shoulder. And they literally, what happens is these roots just get right avulsed right off the cord. Yeah. That's classic of kind of a motorcycle accident. The other times is with when we see you. Somebody had asked about like different types with brachial neuritis. Is it more common? It is more common here in the trunk. Like with birthing injuries, Erb's palsy, that tends to be the root. Yeah, that you get problems at the root. So it's not only do they have all of this, but they also have scapular winging that goes with it. So for me, this is how I look at the plexus for the upper C5, C6 problems. If there's scapular winging and everything's distal to it, it's a root problem. If it's supraspinatus, suprascapular nerve, if infraspinatus, supraspinatus are involved, but there's no scapular winging, and then everything C5, C6 distal to that is involved, I know the problem's at the trunk. If it's just biceps weakness, and you can argue maybe a little bit of lateral pectoral nerve, a little bit of pec weakness with a lot of biceps weakness and numbness and tingling just on the lateral side of the forearm, I know it's a cord problem. That's the easiest way to break it down to look at that. So hopefully that's helpful. Because it'll save you some time. So scapular winging is always a big hint. All right, team, we are at the time. We made it, even though Dr. Shaffer couldn't get his computer working. But I'll stick around for questions. So please, if you want to stick around, any questions you want to ask, you can ask, and I can go back and review some things. I saw somebody that said to go back, ask me if I had to go back and review some stuff, and I will. So let's do this. For those of you that are getting offline, if you don't mind, let's do a wave and turn those cameras on, and then I hope to see you guys at CSM in Houston. Hope some people are coming to Texas for CSM. Thank you so much for coming on. And if you want to stick around, I'm going to stick around for some questions too, if you want to stick on and listen. All right. Thanks, folks. Anybody got a question for me? CSM is in February. Combined sections meeting in February. Oh, why is the answer monofilament? Okay, let's go back to it. You want to go back? I'm going to go back to that one. Don't watch the screen, else you get like a vestibular disorder here. We're going to go through some slides here.